Good morning, everyone. My name is Kendrick. Today I'll be presenting the results of my master's thesis, which is entitled The Automatic Segmentation of Metastatic Prostate Lesions in Gallium PSMA PET-CT Images using Convolutional Neural Networks. Just before I begin, I'd like to acknowledge my supervisors, so Martin, Mubasha, and Pejman, who provided me with significant help and support throughout this project. So just by way of introduction then, prostate cancer, as the name suggests, refers to a malignancy that arises within the male prostate organ. It's a significant problem in the Western world. It's associated with quite high patient mortality and morbidity. It's also the cancer with the highest incidence in males. So if we look at the Australian Institute of Health and Welfare statistics for 2019, 20,000 prostate cancer cases were diagnosed, which comes in at more than double the type of cancer that comes in second incidence for males. So it's quite significant. In terms of patient outcomes, when the disease is localized, we have a very high 5-year survival rate, so close to 100%. But when it metastasizes, the lethality increases quite drastically. And we have 5-year survival rates of about 40% or slightly less than that. Bone metastases are also very common in this instance. Again, if we look at the AIHW statistics, 2019, 3,300 deaths from prostate cancer, so second highest in males, only behind lung cancer. Again, it's quite significant among the male population. So how then do we image prostate cancer? Well, traditionally we might use CT with the bone scintigraphy. We might also use MRI scans, but to a lesser extent. The most important for this research, however, is the use of gallium PSMA PET-CT imaging, which is fast becoming the clinical gold standard. And the reason for this is quite simple to understand. It's because of a protein known as prostate-specific membrane antigen, or PSMA. And this is just a transmembrane protein that's massively overexpressed by about 100 to 1,000 times in almost all prostate cancers. So this allows us to design radiolabeled ligands that can bind to this receptor. And if we attach a positron emitter such as gallium-68, once that preferentially accumulates in the patient prostate lesions, we can measure the resulting photons from the annihilation reaction between positrons and electrons. And if we combine that with a CT image, we can generate a PET-CT image from this. Ideally, what we'd like to have in this is high contrast between the prostate lesions and anything else in the body. So we want to be able to see them quite clearly, and PSMA gives us that. So just by way of a brief literature review, the literature on this subject is quite desolate. There's only been about 2 studies that I know of that have attempted this. The first one was by Zhao and colleagues in 2019. This one came out very recently, just before I started the project, actually. And what they attempted to do was to segment metastatic prostate lesions in PSMA PET-CT images. They achieved quite high DICE scores as well. So they achieved a DICE score of 64.5% for bone lesions and slightly less, 54.4% for lymph node lesions. But the most important to recognize here is that their investigation was only limited to lesions within the pelvic region. So a primary aim of this project is to extend upon their analysis and attempt the automated segmentation for whole body PSMA scans. And whole body is just defined as middle of the thigh to head. The second study, which is sort of relevant but not directly relevant, was by Feldman and his colleagues who attempted just to automatically segment localized prostate adenocarcinoma. They used a different modality, so multi-parametric MRI images in order to do this, again achieving a DICE score of about 64%, so the results are pretty consistent. And what they did was they found that these results were actually very similar to the quantified inter-observer variability as well. So they had 2 observers. So the significance of this project, then, is that manual segmentation is a prerequisite for the extraction of any features we might want to extract from the patient lesions and also for patient treatment planning as well. But it's very time-consuming and labour-intensive. It's also subject to quite high inter-observer variability, as mentioned. So if we can find a way to automate this process, we can save large numbers of hours that can be utilised elsewhere in the clinical process. The aim, then, of this research was to utilise deep learning techniques to assess the feasibility of automated segmentation of metastatic prostate lesions in gallium PSMA PET-CT images using just the patient PET images by themselves, just the patient CT images by themselves, and also the combined PET-CT images in a multi-channel framework. So by way of methods, the data set in this research was comprised of 336 patients, each of which received a gallium PSMA PET-CT scan at Charlie's or Fiona Stanley. The radioactive gallium was eluted from a germanium gallium generator in-house, and the metastatic prostate lesions in each case were manually delineated by a clinical expert. And that served as the ground truth data that was subsequently used to train the convolutional neural network. There were some inclusion criteria as well, so only patients with biochemical relapse following definitive treatment in the form of radiotherapy or surgery were included, where that's defined as having a PSA or prostate-specific antigen level greater than 0.2 nanograms per mil, 6 weeks post-prostatectomy, or a PSA level of 2 nanograms per mil above the previous low point 3 months post-radiotherapy procedure. So just before I jump into the model that was used during this research, a convolutional neural network just involves the repeated application of convolutional and pooling operations in order to extract the salient features of an input image and then to use those features to produce the desired output. Now, it might be a binary segmentation map, which is obviously the goal in this research, but it doesn't have to be that. It can be a regression task like Bryony spoke about previously, so it doesn't have to output just ones and zeros. But in this case, that's what we want. The architecture that was used is called the multi-res UNet. It was developed about 1.5 years ago, and it was developed to be an improvement on the baseline UNet, which was a convolutional neural network developed in 2015, which really revolutionized the field of biomedical image segmentation. And what it consists of is a downsampling portion, which extracts the salient features from the input image while also simultaneously reducing the dimensionality. And then an upsampling portion, which increases the dimensionality and uses those features to produce the desired output. So in this case, we want to produce a binary segmentation mask indicating where in that patient slice the lesion is actually located. And the training procedure, just briefly, sort of goes something like this. So we'll input an image or a selection of training images into the model. It'll proceed through the model, whose weights have been randomly initialized. At the end, it'll output a segmentation mask, and from there, we'll calculate a loss function, which is just a mathematical function which determines how closely our output segmentation mask approximates the ground truth segmentation mask that we actually want it to be. And what it will do then is it'll use that in order to update the weights of the model, and this occurs in an iterative process as many times as we specify, basically. So the two types of loss function that will be used in this research are the binary cross-entropy loss function and the dice loss function. In terms of partitioning the data then, so of the 336 total patients, 252 of them were available from the beginning of the research, and they were used for training the model. So that gave us 6,405 axial training examples, somewhat like you see on the screen there. So it was comprised of a patient CT image, a PET image, and then a binary segmentation mask indicating where in that image the lesion was actually located. We use this to train the model. So they were randomly assigned to a training, validation, and testing set in a 60-20-20 split. And then the remaining 84 patients, which became available closer to the conclusion of the project, served as a completely independent assessment of model generalizability. So we need to test it on an independent set it's never seen before so that we can ascertain how well it performs. And that gave us an extra 1,929 training examples. So important to note at this point is that there'll be two sets of results then. So there'll be the results from this testing set here, which are not a truly independent assessment of model performance, purely because by randomly assigning the lesions to the various testing sets, training, validation, and testing, if a patient lesion typically spans multiple axial slices, the model is being trained and tested on slices it's already seen before. So it's not a truly independent test. These results will be taken to, going forward, give us an indication about how well the model performs on the training data. And then these 84 patients, so 1,929 examples, will be the independent test of the model. Also important to note was that all images were resampled to a common resolution, 2 by 2 by 2 millimeters cubed, using B-spline interpolation for the scans and nearest neighbor for the masks. So in terms of experiments, well, all combinations of hyperparameters were used. So 2 models were trained using just the patient PET images, using both loss functions mentioned before. 4 models were trained using just the patient CT images because it became possible to employ HU windowing as a pre-processing technique when you're using the CT images. And the values that were selected, so a window of 350, level of 40, were chosen because those are the values that are used during the manual segmentation process to aid the manual segmentation process. So it was hypothesized that by using these values, we could improve model performance. Similarly, 4 models were trained using the patient PET-CT images, again, using both loss functions and using with and without HU windowing on the CT channel. But then at the end, the best combination of hyperparameters were used as the baseline to perform 2 further experiments, which modified the learnable parameters of the model. So the baseline model has 7 million learnable parameters, which it's able to update during the training process. 2 further experiments were performed, either increasing it to about 5.5 million, decreasing it to 5.5 million, and increasing it to 9.5 million to see how that affected the performance. So the results. First of all, we need a method of assessing how well our outputted segmentation mask approximates the ground truth. And we do this by positing some mathematical functions known as evaluation metrics. So they just determine how closely our model aligns with what it should be. The American Association of Physicists in Medicine have undertaken a comprehensive investigation on the metrics used to evaluate auto-segmentation models using PET images. And what they suggest is that a combination of metrics are presented in order to provide a full account of the model performance. So just by illustration, we do need to be careful what we use. In this example here, so it's not very clear, but this is the model prediction and this is the ground truth. So there's a false positive lesion in there. But if we use as the metric of evaluation the pixel accuracy, what we'll get is we'll get a pixel accuracy of about 99% or even higher because there's so many background pixels. So that's misleading, obviously. We need to be a bit more careful with the metrics that we use. Going forward then, we have the sensitivity, which is defined as the true positive rates. That's the percentage of foreground pixels that are correctly detected by the model. We also have the precision, which is the probability that a positive prediction by the model is in fact a true positive. We combine these into what's known as the accuracy score, which is a metric that attempts to balance the 2 types of errors that a model can make. So false negatives and false positives. And that's defined simply as the weighted average of sensitivity and the precision. We also have the gold standard evaluation metric, which is used ubiquitously throughout the biomedical image segmentation field, dissimilarity coefficient, defining the overlap between our predicted output and the ground truth segmentation. And like I said, that's really the gold standard in the literature at the moment. It's used basically ubiquitously. But these 2 metrics going forward will be the primary evaluation metrics. So we'll go through the results one at a time. The best PET-only model, we'll start off with the patient PET-only models. The best one was trained using the binary cross-entropy loss function. And just before I jump into the results, so this is a box plot of the results. I'm sure you're all familiar with it, but we have the range of the data. Each one of these dots represents a patient slice that has been tested on. We have the range, we have the upper quartile, lower quartile, and the median. So it just shows the distribution of the metrics tested on the patient slices. Now, on the training data, the model performs actually quite well. So we have a quite favorable distribution of metrics, and we have a mean dice score of 62.6%, which is quite good. Accuracy score of 0.679. For just using the patient PET images, that's really good. However, when we then go on to independently assess the model on the aforementioned 84 patients, the distribution of the metrics shifts quite obviously towards 0. And the dice score and accuracy score decrease as well. So we get a 33.6% dice score and an accuracy score of 0.410. What we'll observe here as well is that the lower quartile is actually located at 0, which means that for 25% of patient test slices, we're not getting a single true positive. Obviously, if we're looking to implement this clinically, that's problematic. So using just the patient PET images, we're able to perform semi-accurate segmentations on the training data, but it fails to generalize sufficiently to previously unseen test cases. If we look at the hyperparameters, we observe that with respect to the 2 primary evaluation metrics, the model that was trained using the BCE loss function or binary cross-entropy loss function outperforms the one that was trained using the DICE loss function. So if we move on to the best CT-only model then. The best CT-only model trained using the binary cross-entropy loss function, and it was the one that employed HU windowing on the CT channel with the parameters specified before. Again, what we observe is that on the training data, even using just the patient CT images, we're able to get quite good segmentation results. So 55.7%, accuracy score of 0.604. However, this is only indicative of a model that is significantly overfitting to the training data, because once we then go on to test it on the independent set, we're not generating basically any usable predictions whatsoever. So using just the patient CT images, we get a DICE score of 2.8% and an accuracy score of 0.044. And there's no discernible box plots basically because the upper quartile is located at 0. 75% of patient test slices is unable to generate a true positive. So they performed by far the most poorly. Overall, they failed to generalize at all to previously unseen test examples. However, this is exactly in line with current literature values. So, as I mentioned, Zhao and his colleagues trained a variety of CT-only models, and for every one of them, they achieved a DICE score less than 10%. And it's also what you would expect, because if you're trying to perform manual segmentation using just the patient CT images, it would be basically impossible. If we do some hyperparameter exploration, what we observe is that if we control for the use of loss functions, first with the DICE, the model that used HU windowing as a pre-processing technique improves over the model that doesn't use it. And similarly, if we control for the BCE loss function, again, using HU windowing as a pre-processing technique improves results. If we control instead for the use of HU windowing, what we observe is that in one case, the model trained with the BCE loss function outperforms the DICE loss function, but in the other case, the DICE loss function outperforms. So moving on now to the best PET-CT model. This one was trained again with the BCE loss function using HU windowing, and what we observe is the best results on both the training data and the testing data. So we get a mean DICE score of 67.3%, which is really good on the training data. Accuracy score of 0.722, favorable distribution of metrics, they're quite high up. But again, when we test it on the independent set, the results decline quite significantly. So we get a DICE score of 34.7% and an accuracy score of 0.425. Again, we see the lower quartiles located at 0, so for 25% of patient test slices, it's not generating a single true positive, which, if we're attempting to implement this clinically, is a problem. In terms of hyperparameter exploration, again, what we observe is that controlling for the various loss functions, DICE and BCE, using HU windowing improves over not using HU windowing. So in every case, when we use HU windowing as a pre-processing technique, the model outperforms the one that doesn't. And in these two instances, if we control for the use and disuse of HU windowing as a pre-processing technique, the BCE loss function outperforms the DICE loss function in both instances. So how do the combined PET-CT models compare with the individual modalities then? Well, if we tabulate the DICE score for all of the models, what we observe is that in all cases except one, the PET-CT model outperforms the models trained using the individual modalities. But in only one of these cases is it a synergistic effect. So in only one case is it super additive to train using the combined patient PET-CT images in a multi-channel framework over training with the individual PET and CT images. And this is pretty clear evidence that the CT channel, if we needed more, is not contributing much to the segmentation algorithm whatsoever. Interestingly, this actually contradicts the present literature as well. So Zhao and his colleagues were able to achieve super additive performance by training with the PET-CT images over the individual modalities by themselves, which I'll discuss further in a minute why that might be. So as mentioned, a further 2 experiments were performed using the best hyperparameters that were achieved in the first 4 experiments using the patient PET-CT models by modifying the number of learnable models in the model. So we used the BCE loss function HU windowing, the baseline model, 7.2 million learnable parameters. If we increase the learnable parameters, what we observe is that the DICE score and the accuracy score both increase. Similarly, if we decrease the number of parameters in the network, what we observe is that both the DICE score and the accuracy score increase as well. So this tells us that the baseline level of model complexity is not optimal when it comes to generating a segmentation of previously unseen test cases. So there's much scope for further experimentation in this respect. We were basically only limited through time. Each one of these models takes a week to 2 weeks to train. So we got through as many as we could, but it seems that modifying the number of learnable parameters in the network is a fertile path to explore in terms of improving these results. However, it's important to note that even the best model achieved as part of these experiments, which was this one here, 0.35, so 35% dice score, is outperformed by the current literature values. So these are two examples of model predictions then. We have the one on the left, where the model actually performs quite well at detecting the lesion and segmenting the lesion, and then the one on the right, where there's two very obvious lesions in the patient PET image, but the prediction is unable to get them. And this is quite indicative of the results. There's obviously a wide range, but they skew much more towards this one here, obviously because of the results. So this all begs the question then, why is the model not generalizing to previously unseen test cases? Well, in my opinion, the primary reason is the lack of three-dimensional context. So the model that was trained, the multi-res UNet, is a two-dimensional model. It's only able to treat every slice as an independent example. It doesn't take into account anatomical and physiological context in 3 dimensions, which would certainly aid it in performing a segmentation. It's just not able to leverage that information whatsoever. And by not including that, it's not able to generate accurate segmentations, in my opinion. Now, there are ways of implementing 3-dimensional neural networks, convolutional neural networks. They're highly computationally expensive, though, and pretty much because we lacked the computational resources, we chose early on to use a 2-dimensional model. However, that's not the only way of accounting for 3-dimensional context. There are other ways, which probably should have been considered at the start of the project, but the results are what they are. Second reason might be because of lost resolution. So the CT and PET images were all resampled to a common resolution, 2 by 2 by 2 millimeters cubed, which necessarily entails losing a significant amount of resolution in the CT images. The variance in the resolution, I believe, was 0.9 by 0.9 in the axial domain. So we're losing over double the amount of resolution there. And by losing that resolution, I think this would introduce some errors as well during the resampling process that's affecting the ability of the model to segment accurately. We're also losing that resolution in the binary mask as well, because the code that develops the binary mask from the manual segmentation uses the CT image as a baseline, so it has the same resolution as a CT image. And if we're resampling those and losing half the resolution, we're losing the resolution in the binary masks as well. So I think that could have affected the performance of the model. Also, not fully utilizing the training data. So only axial slices were used during the training of the models. But what we can do is we can effectively augment the size of our data set by a factor of 3 simply by including the sagittal and coronal slices, because the fully convolutional nature of the network that was trained doesn't require you to specify an exact image size. So they can be different sizes, you can put them in, the model will still train. So this could improve the ability of the model to generalize, and I think if we fully utilize that information, we will be able to improve results. Also, training was done on Google Colab. For a while, it was done on the free version, which for anyone who's aware and used that is an absolute nightmare. So yeah, I was getting kicked off probably every 8 to 12 hours during a training run. So that would allow me to get through maybe 6 or 7 epochs of training before I'd have to reload the model and train it again. The problem is, it's just recently come to my attention that Colab doesn't necessarily save the optimizer states when you're reloading the model. So this could affect performance, although I think that's relatively minor compared to the other factors that I've mentioned here. So just some brief concluding remarks then. This was the first time that anyone's attempted to segment metastatic prostate lesions in whole body gallium PSMA PET-CT images. And although the models performed really well on the training data, they all failed to generalize to unseen test cases. As mentioned, I think the reason for this is the 2-dimensional nature of the architecture was not able to sufficiently leverage the information in 3 dimensions. There's heaps of anatomical and physiological info we can use in all 3 dimensions that the model just isn't taking account of. On the whole, the PET-CT models outperformed the individual modalities, which demonstrates the usefulness of supplying both anatomical and physiological information when you're training a convolutional neural network. And in terms of hyperparameter exploration, if we mimic the HU windowing pre-processing that's used during the manual segmentation process, results are improved in every case. In every case, with one exception as well, using the BCE loss function to train the network outperforms using the DICE loss function. And if we either increase or decrease the complexity of the model by adding or removing learnable parameters, we improve performance. So this suggests that we haven't reached that optimal level of complexity, and there's much more scope for experimentation when it comes to that. So further architectural refinement is definitely required, and pre-processing experimentation as well to generate a clinically viable model. In terms of future work, I think the primary path of future work should focus on 3D CNN implementation, which would, as mentioned, enable the model to leverage information in all 3 dimensions when making a prediction. If there is a lesion in one slice, there is a higher probability that there's also going to be a lesion in the adjacent slice. So the model is completely missing that information. And particularly, we might want to obtain quantitative estimate of inter-observer variability as well. So in this study, we only used one observer. Jeremy, he did all the manual delineations for the entire 330 patients, which is a monumental effort on his behalf. But if we were able to obtain a quantitative estimate of the variability, the results could be put into more context. So we could say, okay, it's outside of the measured variability or it's inside of the measured variability. Clearly, with the results achieved, it's probably going to be outside. But for future work, that's a necessary undertaking. Also, we might want to take full advantage of the training data through data augmentation techniques and utilization of coronal and sagittal slice information. So those are the references, and I'd just like to acknowledge all those people on the screen there. So Martin, Pejman, Mubasha, Jeremy, Angel, you guys were absolutely crucial to this project, and I wouldn't have been able to do it without you. So thank you very much, and thanks everyone for listening.
Okay, sorry for that. A few suggestions I have got it, which I will share with you after the presentation.
Yeah.
When you looked at the res unit, have you tried to increase the layers in it?
I did try to increase the layers, but it didn't seem to have a significant effect on performance. What it did is it actually decreased the performance on the training data. So I sort of ditched that as a path to take. But yeah, within the time constraints I had, I sort of just experimented as much as I could with the baseline model. Definitely, with more time, I would have added more layers, I think. Also, in terms of adding the number of convolutional filters within the actual model itself, I think that would be a sort of good path to follow. Because I only modified the number of learnable parameters by about 50%. If we were to increase that substantially, that might have a greater effect on results. But again, it was all within the time constraints, basically. Yeah?
It was great, Jake.
Thanks.
The best projects are the ones where you learn a lot.
Yeah, well, I've definitely
I
learned.
think if you reflect back and say what you knew about this when you started,
Yeah.
to just 9 months later.
Yeah. In a period of 8 months, it's incredible. But yeah.
I'm sort of interested in the effect of the HU in windowing, so I don't really understand it. Maybe we can talk about that later.
Yeah.
And there's lots of parameters you could vary there, but I wonder if like scaling the HU and the PET SUV might also have an effect, like if you scale it logarithmically, for example, or did some sort of histogram equation.
Yeah, possibly. Yeah, I think that would, with a lot of these things, it's really just about experimentation because you can never really know in advance whether it's going to work. I think that's a good thing to consider. I also think playing with other HU parameters as well, so other windowing and leveling parameters is a good way to go. Definitely PET thresholding though, which might be able to reduce, because if we can reduce the amount of useless information in the image, then the model is going to be able to focus particularly on the stuff that it really needs to learn. So if we can threshold out some useless stuff, that's a good way to go as well, I think. But it's really just comes down to experimentation with a lot of this, so yeah, that's a good idea. Yeah.
Do you think we can actually ignore CT images and just focus on the PET images?
Honestly, I think we could, because, I mean, just looking at the results, the CT is not contributing anything. What I would like to try is, I would like to try performing the automated segmentation with a CT image that doesn't lose any of the resolution. So I think if I had some more time, I would try that out, because then we'd be able to get a better estimate of how it can actually contribute to the segmentation process. If those results are poor as well, maybe we can just ditch the CT image and just focus purely on the PET. But yeah, I think we could.
Continuation to
Yeah.
the same question. In the manual procedure, do they need actually CT images?
Do they need CT images?
Like it is a
I think
process,
it
otherwise they can figure it out or what?
my understanding of the manual procedure is that they use it just to provide anatomical context, because the CT image provides lots of anatomical information. So they're able to use that to determine whereabouts in the body they're looking, I suppose. But during the manual segmentation process, Jeremy utilizes a semi-automated method. So he applies a threshold of 3 standard uptake values, which, to follow on from Martin's question, I think would be a good thing to mimic as well, just to get rid of some of that useless information. But yeah, focusing on just the PET images, I think, would probably be a good way to go. Although, like I mentioned, the current literature results suggest that it's super additive to also use the patient's CT images. That wasn't corroborated here, but perhaps it's worth experimenting further with that. Yeah. Any other questions?
How long did it take just to apply the model to an unseen scan?
To an unseen case, because it took way longer when I was actually calculating the metrics, because just the way Colab works is I had to like manually load the model every single time, so it was a huge pain. But for like one slice, you're looking at thousandth of a second. Yeah, it's basically instant. Yeah. So what I'm saying is, if you put in a whole patient image, you could probably segment that in probably less than a second, or maybe just over a second. So that's the whole advantage of this, basically. We're able to do it quickly. Yeah.
How many epochs did it take for training?
150, so between 100 and 150 for each. The only reason I stopped...
Did you actually stop it as soon as we reached the curve? Or
Yeah,
or that
yeah.
just looking-
So I was, with the validation set, I used that to assess where I stopped the model, and it wasn't improving in performance there. So
Have you seen in the literature anyone trying to do like the 3D convolution that you mentioned?
Yeah.
And if so, how did they get around the ridiculous amount of computation?
yeah, well, not specific for this task.
Better GPUs. that's all.
Yeah. So a common thing that I would find in literature was they were using like a Titan XP GPU, which is like the latest version, and it's it's hectic, obviously. We don't have access to that, so like I said, I was just using the free version of Colab for a while, so that's like, it's not really computationally great. But yeah, they've, not specific for this task, but for other tasks, like I think they've used it for segmenting myeloma lesions, 3D network, and they actually achieve really great results. So this is definitely a pathway to explore. We just need the horsepower to get there. Any questions on Zoom?
Yes, any questions from Zoom?
Yeah, so,
Hi.
Jake, a quick presentation.
Thanks, man.
When you selected the hyperparameters that you were going to change when you were testing the model, why did you select the loss function and did you change the optimizer as well? Is that right?
No, so if I just go ahead, I use the...
All I was getting at was how come you chose those functions rather than, because there's so many
Well,
hyperparameters?
Yeah, well, the dice loss function is like the standard for use in training data sets which have a significant class imbalance. So just what that means is there's an overwhelming preponderance of background pixels and a very tiny number of foreground pixels. And what the dice loss function does is it doesn't take into account true negatives. So by not taking into account true negatives, it's able to more effectively train the model when you have large class imbalances. So I chose that just because it's standard, basically. And the binary cross-entropy loss function is just like a binary loss function for classification tasks, which this can be considered because you're just classifying every pixel as a 0 or 1, basically. So those are the two standards that I chose, yeah. I mean, there's heaps others out there, and there's like new ones being developed all the time. So It's just a matter of time. You can't test them all in 8 months, unfortunately. But yeah, that's it.
Okay, thanks. Any other questions from Zoom? No? That's great. Thanks, Rick.
Thanks, everyone.